Hi, my name is Marilyn Huang. I'm a professor and director of Division of Gynecologic Oncology at the University of Virginia School of Medicine. In this video, I will be joined with Dr. Thaker, who will be presenting the use of antibody-drug conjugates in gynecologic cancers as part of the Optimizing Patient Outcomes with Antibody-Drug Conjugates in Malignancy video series. With me today is Dr. Thaker, and I'll turn it over to her to introduce herself.
Hi, everyone. I'm Premal Thaker. I am a professor and interim division director of gynecologic oncology at Washington University School of Medicine.
Great. Before we get started, I would like to thank our partners, SGO, as well as our project sponsor, AbbVie. And just a brief overview about antibody-drug conjugates. These are a relatively new class of targeted cancer therapies that combine the specificity of monoclonal antibodies with the potent cytotoxic effects of chemotherapy. And so we will be talking about antibody-drug conjugates, specifically the indications in gynecologic cancers and future opportunities. And as of earlier this month, there's about 190 antibody-drug conjugates globally in development, so very exciting. Tisotumab vedotin is the first antibody-drug conjugate to be approved for gynecologic cancers. It received approval for patients with recurrent or metastatic cervical cancer who have disease progression on or after chemotherapy. The antibody-drug conjugate is composed of the three main components: the monoclonal antibody that targets tissue factor, which is a transmembrane protein that is highly expressed in cervical cancer. It's cleavable protease linker, and the payload, the monomethyl-auristatin E, or MMAE, which is a microtubule disrupting agent. You'll also hear us talk about the drug to antibody ratio, or the DAR, which for tisotumab is approximately 4:1. The INOVA-TV301 was a global randomized phase 3 confirmatory study comparing tisotumab vedotin to investigator choice chemotherapy, one of 5 drugs listed here, in patients that had recurrent or metastatic cervix cancer that had progressed on or after doublet chemotherapy with or without bevacizumab, and IO if eligible based on prior GOG 240 and 826 regimens. Patients were randomized 1:1. The primary endpoint was overall survival, and key secondary endpoints were progression-free survival and objective response rate per the investigator, as well as safety. The key stratified endpoints are listed here. The groups in terms of age, performance status, disease status at study entry, histology, number of prior regimens, prior radiation therapy, prior bevacizumab therapy, and checkpoint inhibitor were similar across both arms. The study met its overall survival statistical significance at the planned interim analysis. Tisotumab vedotin showed a 30% reduction of death versus chemotherapy, with a median overall survival of 11.5 months. It had a confirmed objective response rate of 17.8%. There were 6 complete responders and 39 partial responders, compared to 0 complete responders and 13 partial responders in the chemotherapy arm. TV showed a statistically significant and clinically meaningful improvement in efficacy compared to chemotherapy. Overall, the incidence of any grade treatment-related adverse events were similar across both arms, about 85%. 58% of treatment-related adverse events experienced by patients on TV were grade 1 or 2. Treatment-related adverse events were consistent with the previously known safety profile, including the adverse events of special interest, the ocular, peripheral neuropathy, and bleeding events. The ocular events were most commonly conjunctivitis, keratitis, and dry eye. The bleeding events were mostly nosebleeds, but there was also about 10% vaginal bleeding. There were no grade 4 or 5 adverse events of special interest. The mitigation strategies that were developed from the prior phase 2 tisotumab vedotin study successfully prevented more frequent and severe ocular events, such as corneal ulceration. This basically outlines the mitigation plan. It requires a baseline eye exam, including a slit lamp, evaluation by either an ophthalmologist or an optometrist, and follow-up exams prior to each infusion was required for the first 9 cycles and then is clinically indicated. Steroid and vasoconstrictor eye drops were required about 10 minutes prior to infusion to reduce inflammation and to decrease the drug exposure to the cornea. The steroid and drops were continued for 3 days after infusion to reduce the inflammation. Cold packs were applied to both eyes during the infusion to minimize drug-related corneal toxicity. Patients were told not to wear contact lenses during their treatment and throughout their treatment, unless directed by their eye care provider. The other important thing to note was that lubricating eye drops were encouraged to be used as often as needed throughout treatment and to be continued for 30 days after the last dose. So now shifting gears a little bit to mirvetuximab soravtansine. This received FDA approval about a year ago as a first-in-class antibody-drug conjugate and the second antibody-drug conjugate in GYN cancers. It is comprised of a folate receptor alpha binding antibody, a linker, and the payload is something called DM4. That is a potent tubulin targeting agent that's used to treat folate receptor alpha positive platinum-resistant ovarian cancer. These surface folate receptors mediate folate transport into epithelial cells, and expression is limited on normal cells, but it's very highly upregulated in cancers, and particularly in ovarian cancer, but also in the endometrium. Expression varies by histology, with about 75% high expressing in high-grade serous ovarian cancer, about 50% in low-grade serous, and 30% in clear cell. Mirasol was the phase 3 confirmatory study. The eligibility criteria included platinum-resistant disease less than 6 months, and the folate receptor alpha by immunohistochemistry had to have a intensity greater than 75% of the viable tumor cells. It limited use to patients that had platinum-resistant disease with 1 to 3 prior lines. They allowed patients to have received prior bevacizumab and prior PARP inhibitor. Patients with BRCA mutations were allowed, but primary refractory disease were excluded. This was randomized 1-to-1 and compared to investigator choice chemotherapy of weekly Taxol or topotecan and then Doxil. The primary endpoint was progression-free survival assessed by the investigator. The key secondary endpoints are listed here, and the stratification factors that were considered were the induction chemotherapy and by the number of prior lines of therapy. There was a 35% improvement in progression-free survival with mirvetuximab compared to chemo, and a 33% improvement in overall survival with mirvetuximab. The objective response rate more than doubled in the mirvetuximab arm compared to chemo, 42% versus 16%. And there were 12 complete responders in the mirvetuximab arm compared to 0 in the chemotherapy arm. So this slide shows us the summary of the adverse events. Mirvetuximab overall compared to chemotherapy had lower grade 3 treatment emergent adverse events. They had less serious adverse events and less treatment emergent adverse events leading to discontinuation of the study drug. The most frequent adverse events in the mirvetuximab arm were ocular, mostly a grade 1 or 2, And mitigation strategy with ophthalmology was mandatory and typically reversible in nature. This is the summary of the eye care plan, and very similar to what we saw with the tisotumab. It required a baseline ophthalmologic exam with an eye care provider prior to initiating treatment. Follow-up exams had to occur every other cycle for the first 8 cycles. They also used a steroid eye drop and a lubricating eye drop. This one was more specific, requiring drops 6 times daily for the first 4 days, and then 4 times daily for the next 4 days. And lubricating eye drops throughout that time period, at least 4 times a day, but more frequent if needed. Again, contact lenses were to be avoided. So this is the PICCOLO phase 2 study, and this is examining mirvetuximab in 3rd line or later for platinum-sensitive ovarian cancer. So moving it into earlier lines of treatment for patients with ovarian cancer. The primary endpoint for this study was an investigator-assessed objective response rate. There were 79 patients that were enrolled, and it demonstrated an impressive objective response rate of 52% with a median duration of response of about 8 months. There were no new safety signals seen, and just demonstrated an efficacy and tolerable safety profile for platinum-sensitive ovarian cancer patients that were folate receptor alpha positive. Another study, this was a phase 1b/2 that looked at combining mirvetuximab with bevacizumab in patients with platinum-resistant ovarian cancer. They had 94 patients treated with more than 3 lines of therapy, and again, demonstrated a very significant objective response rate of 44%, and had 5 patients that were complete responders. So another regimen that would potentially improve on the standard of care in platinum-resistant ovarian cancer. And with that, these are my references, and I will turn it over to Dr. Thaker.
Thank you, Marilyn. About antibody-drug conjugates, again, in gynecologic cancers, some of them are going to be approved, and some are still undergoing investigation and clinical trial. Here are my conflicts of interest. All of them pertain to drug development, but none to the topics of today. So as we mentioned, we are discussing antibody-drug conjugates, which are relevant to gynecologic malignancies. One of the ones that has always been a good target that we have realized in gynecologic cancers has always been looking at HER2 expression. We know that it's a very viable cancer biological pathway. And in ovarian cancer, it's thought to be overexpressed in 1.8 to 76% of tumors. Remember, there's many different ways to measure overexpression. So it can be by immunohistochemistry or FISH, most typically, but sometimes even by ELISA. In uterine cancer, we do know that in uterine serous cancer, which is considered to be a more aggressive histology, that we do see that there's an overexpression as well, ranging anywhere from 14 to 80% by immunohistochemistry. And then in endometrioid types, which are much more common, but especially in the patients who are more of the high-grade endometrioid types, so typically a grade 3, that it's usually between 0 to 38% that we see this. Additionally, in cervical cancer, it is seen, but it is to a lesser extent, to anywhere from 5.7 to 27% that we see this overexpression. So previously to the ADCs, we did use monoclonal antibodies such as trastuzumab in ovarian cancer to see if this would be a relevant therapeutic option. However, we did not see good results in those trials. Fortunately, with the advent of ADCs, we have, like Dr. Huang mentioned, the ability to have an antibody target along with a chemotherapy in order to hopefully get more bystander killing as well as more selective killing of the cancer cells. The payload for trastuzumab deruxtecan is topoisomerase, which is a commonly used chemotherapy in our cancer types. So there was a large trial called the Destiny Pan Tumor Trial, which was a phase 2 trial looking at the use of TDXD for any type of HER2 expressing solid tumors. So the key eligibility was that this was used as a second line in a patient population where their tumors had to express either IHC 3 or 2 plus, and the scoring varied based on the tumor type, but for gynecologic cancers, it was really using the gastric scoring methodology. Prior HER2 therapy was allowed, and you had to have a good performance status. What's interesting is even though this is a basket trial that had bladder cancer and GI cancers, such as biliary or pancreatic, the cancers that seem to have done extremely well were the gynecologic cancers as part of this basket trial. So endometrial cancer, what you can see is that overall the response rate was known to be 57.5%. And importantly, if you had IHC of 3 plus, it rose to up to 85%. And then if it was 2 plus, it was 47.1%. And what you also can see is in cervical cancer, there was also a huge improvement in overall response, where for all comers, it was 50%, and then for IHC 3 plus, it was 75%, and then IHC 2 plus was known to be 40%. And then in ovarian cancer, we saw similar results as well, with the IHC 3 plus performing at 63.6% and at 2 plus of 36.8%. Remember, these are small cohorts of about 40 patients, and so there is a larger phase 3 ongoing trial to show the confirmation, but this is very exciting for all of us who are in drug development, since we don't typically see such great overall response rates. And then also I would point to you at the bottom of the graph is also the median duration of response, which was anywhere from about 11 to 14 months for both ovarian and cervical cancer respectively, and not even reached in endometrial cancer. So this is showing it in a graphic of survival based on the IHC levels. And you can see that really the 3 plus patients tend to do, of course, better, as we mentioned on the prior slide. However, I think graphically you can see that patients really benefit from the drug as long as they have a HER2 staining of 2 to 3 plus in general. So what are the key safety issues? There are definitely treatment-related adverse events that are associated with this. So about 20% of patients did require dose reductions. There were some deaths on this trial, but overall a low percentage with less than 2%. But the more common drug-related adverse events that we saw was nausea. So it's really important that you have a good antiemetic regimen that you give these patients. There's also fatigue, because I am focusing on the grade 3 adverse events, which I think are what most of us as oncologists or in the oncology field are most worried about when we're discussing with patients how to mitigate these adverse events. The other is neutropenia, anemia, as well as you can get thrombocytopenia. And lastly, there can be some diarrhea as well. So it's really important to let patients know about the side effect profile. One of the other issues with a lot of the ADCs, especially with TDXD, is that there is the concern for interstitial lung disease and pneumonitis, which, as many of us know, is a very hard side effect to sometimes detect, especially depending on where you practice, since a lot of patients may have some scarring that's seen on their CT scans. I practice in the Midwest, where we do see a lot of just changes from environmental factors. So having a baseline CT scan, a high resolution CT scan of the chest is really important. Additionally, asking patients a good pulmonary history is important to know what are their baseline characteristics. We here will use a baseline pulse oximetry, and if there is a patient that we're concerned about, we may even suggest that the patient buy a pulse oximeter to keep at home, since they're very readily available and not too expensive. We've also realized the importance of a multidisciplinary approach if we are having concerns or questions before even starting, to involve our pulmonologists as well as our radiologists to try to help us look at the scans even more effectively. And we really try to educate our patients to let us know if they're having symptoms. So if they develop a cough, if they have a fever, they feel short of breath, to really let us know as our oncology team so that we can try to intervene as soon as possible. So as long as we feel that we're able to, handle these symptoms or not too concerned, we do try to also use radiographic imaging at baseline, as I mentioned, and try to repeat it every 12 weeks. And if it's somebody who's symptomatic, try to decrease that interval of CT scanning to every 6 to 9 weeks. Some institutions have actually developed pathways for evaluating pneumonitis as well as for monitoring it. So I would refer you to your own institutions or hospitals to see if your pulmonologist may have this, since there's lots of ADCs that cause similar side effects. And then I think, it's also important, as I mentioned, is to just also make sure that the patients are very well informed about this side effect, since in rare cases it could be fatal. If there is also a concern about if this is interstitial lung disease, sometimes you may require bronchoscopy to be utilized, or even ABGs to help sort out the diagnosis. I definitely know that during this viral syndrome or season that we've had lately, it's been really challenging sometimes to differentiate what might be a viral issue versus really a side effect of the medication, since a lot of our patients have been presenting with coughs and fevers for other reasons. So I just make this well known so people know that there are strategies to help minimize these side effects. So as Dr. Huang mentioned, there are lots of ADCs in development, and there's obviously a concern for all of us that how do we pick which one and what sequence, which I think is going to be really exciting for all of us to learn how to best utilize this. But you can see there's a multitude of targets that we've talked about, several already, like folate receptor alpha and mirvetuximab, but there's TROP2 ADCs, there's B7H4 ADCs that are in development. Some of these have also just recently read out at our recent Society of Gynecologic Oncology meeting that was just held this past week. One of the ADCs that's under development is luveltamab tazevibulin, which is a tubulin inhibitor antibody-drug conjugate, which is really looking at the use of folate receptor alpha as a good target. However, for patients, you only need to have expression of a tumor proportion score of greater than 25%. Unlike mirvetuximab, which we discussed earlier, that needs to be at 75%. So this really widens the pool of patients that have the availability to receive this ADC, since we believe that 80% of the platinum-resistant patients have this percentage of greater than 25% of folate receptor alpha intensity. The adverse events are also different than what we saw with mirvetuximab. We do not see any ocular issues. However, we do see myelosuppression as well. So that is the biggest side effect, and we don't see ILD either. So as I mentioned, that was a big side effect for trastuzumab deruxtecan. So the data that we originally saw is from the initial phase 1 trial, which was the Reframe 01 trial, which looked at 92 patients. The majority of the patients had platinum-resistant disease. They had 3 prior lines of therapy, as you would expect in a patient population like this. They had prior bevacizumab and PARP inhibitors. And you can see from this waterfall plot, when they were looking for the dose escalation in this, that there was noted to be quite a significant decrease in the tumor volumes and the target lesions. So this was very exciting to see this waterfall plot in patients who had multiple doses, but also had this lower intensity of immunohistochemistry staining as well. So based on the results of that trial, which you just saw, there was actually the Reframe 2/3, which is named GOG 3086. It is trying to prove whether the overall response rate that we saw in that phase 1 could be demonstrated with now a more precise dose. So this is looking at patients with platinum-resistant ovarian cancer who progressed less than 6 months to their last platinum and had to have either 1 to 3 lines of therapy with a good performance status. However, patients could not be platinum refractory, and they must have had at least a folate receptor alpha intensity of greater than or equal to 25%. So there was 2 doses evaluated at 5.2 milligrams per kilogram, which was given for the first 2 doses, and then it was decreased to 4.3 milligrams per kilogram, and you did require GCSF support due to the fact that there is neutropenia, versus dose B, which was looking at 4.3 milligrams per kilogram given every 3 weeks. So we did get some interim analysis reporting from our recent Society of Gynecologic Oncology meeting. And what we learned is that the 5.2 milligram per kilogram dose had an approximate overall response rate of about 32%, and the dose B of 4.3 milligrams per kilogram had approximately a 13.5% overall response rate. So based on this, the larger phase 3 trial will be proceeding with the 5.2 milligrams per kilogram dosing for the first 2 cycles, followed by the decreased dose of 4.3 milligrams per kilogram versus investigators' choice chemotherapy. And we'll await those results to see if we'll be able to expand the opportunity for more patients to receive an ADC to folate receptor alpha. So hopefully in this brief podcast that we've had the pleasure of presenting today, what you can really see is there's an explosion of ADCs, and we're really going to have to be strategic in how we sequence our ADCs, as well as the fact that we'll be able to offer ADCs to many more patients in many different lines of therapy, as well as in all of our gynecologic malignancies as well. Here are my references. And on behalf of myself and Dr. Huang, we'd like to thank you for listening to our podcast today.